and welcome to all of you who are participating. I'm happy to be sharing with you some information about these new scales, which actually are going to be released as of this Sunday. And you can get more information about that online, but what we're hoping to do today is to give you some idea of how these new scales are offering a way of assessing children and adolescents and adults who may have ADHD and possibly some other problems along with it. So this is gets my background. I am the author of the Brown Attention Deficit Disorder Scales that were published, the adolescent and adult forms in 1996, and then in 2001 the new child forms, and now we are introducing the new Brown, they've changed the name of it a bit, Executive Function / Attention Scales. And basically what we're trying to say is that attention is about executive function. That one way of thinking about ADHD is that it's a developmental impairment of the brain's management system, its executive functions. Now, I'm not going to spend a lot of time talking about those basic, the model on which this is based, because we've already had 2 webinars which are accessible to you if you'd like to get that in more detail. But I'd like to take a minute just to refresh your memory if you are already familiar with this, and if not, if you haven't seen it before, to give you a brief glimpse of what the model is that we're working on. This is a model which was developed over many years of talking with a lot of patients, kids and adolescents and adults, to try to understand what their experience has been in terms of ADHD. And I think most of you are familiar with the fact there's been a lot of talk about executive functions and many different ways of conceptualizing it. I don't say this is the only one. This is one that I've developed that works reasonably well for me and apparently for a number of other people. But let me just make a few comments about this. You can see here that there are 6 clusters. And each of these ought to be thought of not as a unitary variable where it's all one thing, but rather as you might think of them as labels on baskets of related cognitive functions. Organizing, prioritizing, and getting started to work. Focusing, sustaining focus, and then shifting focus when you need to. Regulating alertness and sleep, and sustaining effort and processing speed. Managing frustration and modulating emotions, which is not part of the DSM criteria, but it ought to be. Most of us who work in research in this area agree on that matter. Utilizing working memory and accessing recall, and then monitoring and self-regulating action. A couple of other things to say about this. One is that this is a model of executive functions, and that in doing tasks that involve executive functions, usually it's not going to involve just 1 or 2 of these. It involves dynamic integrated action with all of them. The second thing to mention is that for the most part, these operate unconsciously. Not in the old psychoanalytic sense of unconscious as repression, but rather in the more modern sense of automaticity, that they happen so fast that it's not something that you usually have an opportunity, unless it's a very unfamiliar task to you, to be able to plan your moves. So let's just take a quick look at what each one of these involves. You can see that the citation at the bottom of this page is my most recent book where I tried to explain this in more detail. Organizing and prioritizing has to do with getting one's stuff organized, but also prioritizing and deciding which things to do first, getting some idea of how long it's going to take you to do it, and then the one that we hear about most often with regard to students and adults with ADHD is they have a lot of trouble getting started, a lot of procrastination. So this is a cluster of questions that are on the rating scales that try and address these issues. The next one is talking about focus, but the emphasis here is not on focus as in staring at one particular subject. It's more like focus on your driving and being able to stay focused on what you need to, but at the same time then being able to shift focus when you need to. And the reason I've got this item at the bottom about forgets what was read is that there are 3 questions about reading that often will allow you to pick up a particular problem that many people with ADHD have when they're reading something that in which they don't have any particular interest. That what they'll tell you often is that they can understand it perfectly well at the time they read it, but then by the time they've read that paragraph or that page and then go on, they haven't really been able to get it set in their working memory so they can hang on to it. And so they get distracted, often have to go back and read things repeatedly. So that's one specific form of needing to work on problems with focus, but then also shifting focus. Sleep and alertness are issues that are addressed by these scales. Being able to sustain interest in the task. One of my favorite examples about this is a college kid on the track team who said, my mind's a great sprinter, but it's a lousy distance runner. And then the processing speed becomes an issue. That particularly in writing, many of the people who have ADHD report that they may have good ideas about what to write, but it takes them half a forever to get the sentences and paragraphs out on the page. Managing frustration and modulating emotions. And this is the cluster that is not included in the DSM-5, but these scales go beyond DSM-5. They include the DSM-5 diagnostic criteria, but they go on to pick up on issues in clinical and neuroscience research that, in this case, are talking about some problems that are very typical for people with ADHD, that they have difficulty managing emotions. That when an emotion, whether it's something they're annoyed about, or feel hurt by or disappointed in, or that they really want, or that they're worrying about, it can invade their consciousness like a computer virus can invade a hard drive. And it's very difficult for them to put it to the back of their mind. Memory. Many people with ADHD have very good long-term memories, but they have a lot of difficulty remembering what happened just a couple of minutes ago. And being able to hold online something while doing something else, remembering what it is you intended to remember later today. And also that working memory as a search engine for the brain and being able to pull out the relevant information, what you need in the given moment. The sixth cluster is not just about hyperactivity and impulsive behavior. It has items related to that. But you'll find that many people with ADHD have difficulty controlling their actions. Sometimes they're too slow when they need to speed up, and other times they're too speeded up when they need to slow down. Often they have difficulty sizing up social situations adequately and find it hard to monitor and modify their own actions to fit what the circumstances are in which they're operating at the moment. So that's just a quick look at the model. And it's important to recognize that people with ADHD are not all alike. There are some who are going to have more difficulty with one of these clusters than with another, and that also can change as they get older. But right now, what I'd like to do is to move on and talk with you a little bit about some cases that we've put together, because I think that as a clinician, I spend 5.5 days a week seeing patients when I'm in town, and that's the way I learn best, and so I'd like to suggest it. But one of the questions that people ask is, all right, well, what about the scores for this system? How do you tell if somebody's responses on these new Brown scales are in a clinical range? And we've looked at the data very carefully, and what we've come up with is this this T-score range. That if somebody's scoring on this particular scales, these clusters, these 6 clusters, so their total score is a 54 or below, it's possible they've got an ADHD, but it's not very likely. Their responses are typically, a characteristic of people their age, because all these are age-normed. But if the score gets up in the 55-59 range, that's somewhat atypical, and it's quite possibly a significant problem. 60 to 69, that's more moderately atypical, and there's not much question about is that a significant problem. And then once they get up above 70, that's really up there, and it's usually a very significant problem. But of course, as clinicians, you know that sometimes people, will take a particular slant on how they're going to respond to these things, and sometimes they minimize their scoring so as not to make it look as though they're so impaired as they might be. And some people are likely to score everything at the max, and therefore be in a situation where it makes it look like they're way worse than they are. So you need your clinical skills to pay some attention to how people are attacking the task of responding to these items that are available in self-report form and then also in parent report form. The details of that are available to you. But let's look at a kid. This is a 5-year-old boy, Harper, and he was a very active preschooler, so much so that the people who were running the preschool felt like they really couldn't take care of him, that he was exceedingly impulsive and had to be watched very, very closely all the time with somebody close enough to grab him if he moved. Had a hard time sitting down for more than just a couple of minutes. And the mother reported that he also had a lot of difficulty in falling asleep at night, that often he'd be awake long past the time when the rest of the kids in the family were already asleep, and then he'd be making a lot of noise about him. So the question now is, okay, well, how does this look when we got the report from one of the teachers who had been working with him? And how did it look when we got the parent report? Because with the 5-year-old, we're not asking for self-report yet. And here you can see the scales. The black dots are showing you the parent form, parents' responses, and the blue lines with the little squares attached are the teacher responses. And you can see both of them are pretty close together in terms of being able to get started. And they don't disagree much in terms of focus. But in terms of the effort, the teacher's not reporting quite as much difficulty as the parent is in terms of getting them to do it. And of course, keep in mind that each of these people is responding in terms of the setting in which they see the kid. Now, the place where you see the biggest gap between these responses is on the emotion side. And the teacher's response it's in the clinical range. It's a 62. But the mother's response is quite a bit more. She's seeing a lot more emotion from her son. And now remember, with all of these things, the further up you go, the more problems the person's reporting. So it's higher scores indicate more impairment. And in the memory here, the mother's saying, hey, Harper doesn't do very well about remembering things when you talk to him. And the teacher is saying, well, I see some of that. She's scoring it as 65, which is above the mean, certainly. But it's not quite as much. But what both of them are showing us is there's a lot of action going on here. And the mother is reporting much more action. The pre-K teacher is still in the same range as the mother. So when we're looking at this, the first thing we want to do is just take a look at how did the total scores look. And this composite score here, and we're looking at these are all T-scores, are saying, so just the 78 and the 73 that the teacher's reporting, both of those are in the markedly atypical range. And they're saying, yeah, this kid, compared to other kids his age, is having a lot of trouble right now with symptoms of the kind of impairment that you see with ADHD. Now, later, I'm going to be talking about some specific item responses that you might want to look at. But what we're looking at right now is what's the profile look like? Where is the difficulty most clear? And you can see the mother's having a lot of trouble with this boy. And the teachers actually had asked to have the kid removed. The mother was worried that he would, for example, pick up his little brother and wasn't strong enough to hold him very well. And the mother was afraid that at a time when she's not able to see what's going on, that he actually, it might hurt his brother, but not deliberately. So this was a situation where we were able to work with the family to address these difficulties in terms of some medication for him, and also to work with the mother and also the father to try to develop a behavior management system. He was not accessible to learning and working with the behavior management system very well until we actually got the medication on board. So this shows you a range of scores that are all up in the markedly atypical range for his age. Teacher's not seeing quite as much of it, but she doesn't have him 24/7. Let's look at another case. This is Emma, 7-year-old girl, 2nd grade. And she's in a school program and then an after-school program as well. And the report is that she behaves pretty well there. This is a girl who was adopted at birth, and her biological mother had been addicted to opiates. And what the parents reported was that there was a lot of very extreme oppositional behavior with protracted tantrums going on throughout the day. And anytime she was frustrated and did not get what she wants immediately, she would run her mouth and at times go and hit or kick her mother. The mother was terrified by all of this and was enraged with the kid. And what she would do at the time that she was presenting with her daughter is she said, I just go in the bathroom and lock the door until she calms down. So what we've got here is a kid that's where there's let's take a look at the rating scale. And what you can see here is there's a big difference in terms of the overall picture of how this girl is looking at home. That's the black line at the top. And how she's looking at school. And it seemed that the teacher was maintaining enough structure in the classroom and stability that Emma was actually managing. She was not an easy child to manage, but she was not off the wall. Whereas the mother was basically experiencing a total loss of control in terms of managing her daughter. So, this is an example of how you want to be sure to take a look at who's reporting and what are the differences in the setting. Because, there's some kids that, I think most clinicians are familiar with this, that there's some kids who behave very well at home and make a lot of trouble at school. And then there's some others who make very little trouble at school, and they behave in that structured setting, and that's certainly the case with Emma, but get out of control at home. And sometimes that's just because these kids need more structure, and sometimes it's that the parents have gotten locked into a pattern of interaction with the kid that just throws gas on the fire. But I'd like to call your attention to one other fact that we got. We always ask to get a physical for a child, and we noticed that there was a pattern in terms of the time of day when she was having a lot of difficulty. She was very moody in the morning, early, and in late afternoon. And when we had the pediatrician do an evaluation on this kid, what we found was that she actually had the type 1 diabetes. Her blood sugar levels were out of control. And it's important, I think, when we look at things like this, not to assume that it's all ADHD, that, it's certainly an ADD profile in terms of the symptoms, but the cause in this case was not completely, by any means, it was not completely the ADHD inherited from the biological parents, but that was a piece of the difficulty, certainly, but what was also going on was that her blood sugar levels were bouncing all over the place, and once they got her stabilized in that, she was better able to cooperate at home as well as in school. This is Sophia, 8-year-old girl, 3rd grade. And the report was that she was really very bright and was strong academically in all the academic areas, but she just disliked school and was saying it's so boring. At home, the parents were saying they didn't have any specific problems with her, except that she was always coming up with stomach aches or headaches or other reasons why she did not want to go to school. And at school, the teachers were saying, well, it seems like she can't stay on task very well. She tends to be very forgetful. You give directions, and by the time you finish the 3rd step, she's already lost what was presented as the 1st and 2nd step. And it seemed to take her forever to get whatever tasks were assigned done. So let's look at how this shows up in the rating scale for Sophia. And you'll notice that we've got here now, this is a 7-year-old, or 8-year-old, I should say, in 3rd grade. And what we're looking at is the self-report, because for 8 to 12 we do have self-report, and the kids can often tell you a lot of important information. And so the round black lines with the circles on them, that's the parent report. The blue one is the teacher report, and then the diamond one is the one that's the summary of the reports yielded by Sophia herself. And let's take a look at what we can see. What are the interesting differences in the group? Well, one of the things is that the 70 that we're looking at under emotion, which is coming from Sophia. You know, she's reporting a lot of emotional difficulty, which the teacher's not commenting on, and there's not that much notice to it given by the parent report. You know, they're all pretty close together in terms of issues about getting organized and getting started, and you know, able to focus, sustaining the effort, that's a little more problematic, and you can see that with it. But notice how little there's evidence of the emotional stuff. This is a situation where you'd want to check that out and ask a few more questions of this girl and about her parents to see what she's responding to that's talking about the emotions. Memory doesn't seem to be as big a thing. She's a little bit above the mean. And then with the action, you can see that the mother, who's got her hands full, primarily because of the kid's resistance to going to school, but in the self-report and also in the report from the teacher, not so much behavior difficulty at all. But when you put all this together, we're looking at a profile that looks an awful lot like ADHD. And there was one interesting thing that gets picked up here, and the question is, why is this kid so resistant to going to school? And one of the things that she mentioned was she didn't want other people looking at her. And what that suggests to me, and it turned out to be the case as we looked at this girl a little closer, there's a lot of social anxiety, where she did a lot of worrying about what are other people thinking of me? How do I look to them? And you know, that was something that she felt she had to avoid because she just worried that it was going to be a very negative view. And that was something that she was showing us in the emotion scoring, but it wasn't very apparent. Okay, now we're looking at Robbie. He's 10 years old, 5th grade, tall, a bit overweight for his age. And the teachers were noticing that he just seemed unhappy a lot and sort of preoccupied. He was bright, he was getting good grades, but often would not complete written assignments or homework assignments. And he had a lot of complaints about being teased at school because the kids kept calling him fat. And then his way of responding to that, his response to that was to, basically throw gas on the fire, and was, encouraging the kids because it got more interesting. He had a lot of solitary activities, playing video games, and he'd take play dates, but only with younger kids. And the parents were worried because they figured he's going to be going into 6th grade, which was where middle school would be starting in their school system. And they were worried about his being able to make that transition. As we looked into it a little bit further, this is a boy who was socially rather awkward. And he was depressed, but he was also needing quite a bit of help in terms of being able to recognize what the impact was of some of the things he was doing to try to fight back when the kids were teasing him. And the avoidance was a big problem, but also the way he was running his mouth. And you can see, in this case, as we're looking at his scores, for Robbie, the blue is the teacher report, and she's not seeing that much. But the self-report, the gray one, is peaking around the emotional concerns. And he's having a significant difficulty with memory, not so much difficulty with action, but you can see how it certainly pulls up into the area where this is certainly worth looking at. Let's look at Alex, 13-year-old, 7th grade. He had a lot of trouble transitioning into middle school. Didn't seem to be able to keep track of his assignments and the subjects, and particularly had difficulty with memorizing. He was taking Spanish and social studies. And he spoke about how when he had to write essays or book reports, that often he had good ideas, but that he had to get each sentence to sound just right to him before he could write the next sentence. And this was a very tedious way to do it. And in this particular situation, as we dug into it a little bit more, what we found was that he was having difficulties not only with memory, but also with OCD. And I'll talk a little more about OCD later, but it's a perseverative perfectionism, where it had to, this is the kind of kid who will be drawing a picture, and then if there's some little flaw in it, we'll tear it up and want to start all over. And we'll try to write down a sentence, and if it's not good enough, then they have to change it over. And there's not one specific thing on these scales that picks up OCD, but there are a couple of items where you want to take a look at it when you've got something like this where there's he has this tedious way of trying to get to it. And his memory, is looking pretty high. The memory scores are 76 from the parent, and self-report. The teacher hadn't seen that so much. Here you can see his scores. And there's a lot of differences, but you'll notice that memory is way up there. Not so much in the way of acting out, but, this is a little bit of a spread. But, certainly the report was suggesting that he was having enough difficulty that need to be looked at a little further. This is Daniel, 16-year-old, and he asked his parents to get him an evaluation because his grades were going down, and he felt like he was spending an awful lot of time studying, and then often couldn't remember what he had studied when he went to the next day. He was a really strong athlete, and he was a star of the soccer team he was playing on, a youth soccer league, travel team. But he just had these complaints that when he studies for a test and has the answers when he's quizzed at home, then he feels like he's got it under control, goes to class the next day, and then a big chunk of what he knew the day before seems to just evaporate on him. and also complains that when he reads something, unless it's something that is really interesting to him, it's exceedingly difficult for him to remember. This is not a hyper boy, and teachers over the years had not suggested that he was a candidate for thinking about ADHD, but take a look at what he's reporting here. The self-report for the memory is pushing up the roof. He's at 65. And the parent report, we don't have a teacher report on this one, is up above the mean, but it's not picking up as much, because sometimes kids can't tell you all the difficulties until you start asking some specific questions. But in this case, his memory was typical of the kind of problem you get with kids with ADHD. It's like if they are doing something they have strong interest in, often they can remember things quite well. But if it's not something that they have strong interest in, then it's often very difficult for them to be able to keep in mind what they just read. Okay, this is Kendall. Kendall was 19 years old when he came in. He had just finished his first semester at college and looked quite depressed when he came in. He'd been diagnosed with ADHD when he was in 9th grade and responded well to medication and to the support that his parents were giving him, some extra tutoring. But in his first semester of college, he had failed all but one of his courses. The one course he passed was one where he felt the teacher was particularly interesting. But he hadn't been able to tell his parents that he had sort of lost the grip on his courses, and he had eventually stopped attending classes. And when we looked into it, there are a couple of things that had gone on. One is he had medicine to take that he had been finding helpful in high school, but he just stopped taking in college. He wanted to just be on his own and show that he didn't need it anymore. And then he was hanging out with a couple of other kids in the dorm who were smoking quite a bit of weed and was drinking quite a bit. And the more he was having trouble with school and lying to his parents about how he was doing, the more important it became to pay some attention to this. But nobody knew until he finally came home at Christmas break and said, "Hey, look, there's something I have not been able to tell you." And all we've got here is a self-report, but you can see that he's peaking at problems with memory. And in this case, the issue was not so much action in terms of excessive hyperactivity or restless behavior, but he's way up in terms of problems with sustaining effort, and had difficulty with his sleeping during the day often and not able to sleep at night. A lot of difficulty getting started on tasks, and he was not reporting a lot of trouble with emotion, mainly because he was so dulled out from the drugs that he was taking and from the drinking. But he was sweeping all that under the rug, and he was in a situation where he needed to take a semester off from school to get himself involved in some psychotherapy and get back to using the medication he had, and also to deal with the substance use difficulty that he had had. Okay, we have one more case, and this is a woman who's 43 years old, and she worked as a registered nurse in an intensive care unit. She'd been very successful as a nurse for several years, had been promoted to nurse manager, and then began to feel like there was just too much going on. She had a daughter who was 15, who had been diagnosed with ADHD about a year earlier and responded well to medication, but Ruby, the mother, had no previous history of ADHD in her earlier years. And this is an instance where we saw a problem that our group has done research on, and that is that we have found that there are a number of women, mothers of kids who had ADHD, who are coming in, and when we go through the checklist with them about the symptoms for their kid, they'll say, I didn't have this problem when I was in school, but it seems like I'm having a lot of trouble with my short-term memory, a lot of trouble getting organized and get it started. and then being able to make things work. And now on top of that, things are getting a lot worse at school, since I have to be the nurse manager and not just taking care of a few patients. And what we've learned in those studies was that there is a phenomenon among many women in the perimenopausal period where the estrogen drop creates a problem, because estrogen is one of the primary modulators for the release of dopamine in the female brain. And in this particular case, if you take a look, Ruby is reporting that she's having a lot of trouble getting started on things. She's having difficulty sustaining focus. She's working hard and putting out the effort, but is just feeling overwhelmed by it and is feeling like her memory is giving her a lot of difficulty. We've published 3 papers now that are available on my website about women with perimenopausal women who report no previous history of ADHD until they hit menopause. And then they start showing a profile. They don't necessarily hit all of these clusters, but in this case, she was feeling overwhelmed at work by symptoms that were typical of ADHD, and not because she'd had it all her life, but rather because she was in her menopause and the estrogen level had dropped significantly for her. So these are a few cases that I think it's worthwhile to take a look at. And what I'd like to do now is to talk a little more specifically about different types of disorders that go along with ADHD. And the comorbidity, this is basically just another way of talking about 2 problems at the same time. And talk a little bit about some of the implications of this. The first thing that's important to know is that in at least half of the cases of kids that you're going to see who have ADHD, there's going to be something else in the package. And if you look at adults, they did a national epidemiological study, and they found that among adults, if they looked at them at about 44 years old, they were 6 times more likely in their lifetime up to that point to have at least one other psychiatric disorder. It could be depression, it could be anxiety, it could be substance use. The fact is that ADHD is often accompanied by some additional problem. And when you read the literature on this, you can see that sometimes they're reporting cross-sectional studies where they've just asked people, in the last 6 to 12 months, how much difficulty have you had? Other times, the studies are reporting lifetime rates. Have you ever had problems with this? Now, that one is a little quirky, because if you had somebody who had a significant drinking problem back when he was 22 in college, it would still be counted as a comorbid disorder, even though he may have been long past having that difficulty. And then there are dynamic waxing and waning things. For example, OCD tends to get better, it gets worse. And then there are the subthreshold cases where there are some people who may not meet full diagnostic criteria for some other disorder, but it's still making an awful lot of trouble for them. So that's the background. This is a model that many of you may have already seen. It's back that old study, MTA study. But the point of it is that the large circle represents all the kids in the study. And what they found was that 70% of those kids, and we're talking about kids at ages 7 and 8, who at least qualified for one of these other disorders along with the ADHD. But they didn't include learning disorders. They were only working with combined type ADHD, and they were just 7 to 9-year-old kids, and it was very cross-sectional. So the fact is, comorbidity is a bigger problem than even that data set shows you. If you look at the adolescent studies, what you find is the frequency of adolescents qualifying for a diagnosis of a mood disorder, about 14%. More than double that for an anxiety disorder. Behavior disorders, about 20%. Substance use disorders, a little over 10%. Eating disorders, about 3%. But any disorder, 49%. But look at this. How many people had just one of these things? About 58%. But then you've got 24% who have at least 2, and 18% who had 3. So the point is, when you're looking at somebody with ADHD, you want to consider the possibility that there may be something else going on. These are the data from that adult study I mentioned. These are odds ratios. An odds ratio of 1.0 means it's the same as the general population. And the bottom line here, if you look at this arrow on the lower right corner, when looking at lifetime for these adults with ADHD, they had 6 times the likelihood of having at least one other disorder, mood, anxiety, substance use, impulse, at some point in their lives. So when we're looking at ADHD, we're often having to look at some other things as well. And the question people often say, well, why is it that these people, are they just unlucky that they've got so many things going on at the same time? Well, if you think about the model that we have, ADHD is the developmental impairment of executive functions. Now remember, executive functions can be damaged in other ways as well. If you hit your head hard enough in a motor vehicle accident, and depending on what kind of damage there is to your head, you may see impairments in executive function. Likewise, if a person has a stroke, that may cause impairments of executive function. Executive function impairments are among the first signs of Alzheimer's or other dementias. But in those cases, usually people have had adequate executive function and then lost it secondary to the tissue damage, when in fact, in the case of ADHD, it just has not unfolded yet. And so what I'm proposing here is that ADHD is not just one disorder among many, that it's a foundational disorder that cross-cuts a lot of other disorders. You know, think about it this way: if your PowerPoint program goes down, you're going to have problems doing slides on your computer. But if your operating system goes down, that's going to impact a lot of other things. So this is just a way of calling attention to the importance of looking, not when you're looking at ADHD, consider other things that might be going on as well. And these numbers are showing the reported percentages. The numbers range wide because of the fact that there have been a lot of different studies that come out with different numbers. But anxiety and depression with ADHD, you know, the most adequate studies, I think, show that in the general population, it's about 5% of kids. If you look at kids with ADHD, it's pushing closer to 30 to 35%. Depressive symptoms, 14 to 22%. We don't have good data yet on disruptive mood regulations, but the question is, okay, when you see something like this, what do you want to do? Well, the main thing is what's making the most trouble. If you've got somebody who's suicidal, wondering about whether or not they want to stay alive, or their vegetative signs, eating and sleeping are screwed up, then those things have to get priority in terms of getting some help for them. However, you know, or severe panic disorders. However, there also are some where if you've got some depressive symptoms, like the one kid that we had in the example I gave before, if you treat the ADHD, often that helps to take care of some of the emotional symptoms as well. Medications that you give for treatment of anxiety or irritability, in the ADHD medicines sometimes will jack up a person's anxiety, but the meta-analyses show that in many cases it helps it. Bipolar disorder is controversial in terms of you know, kids. The group at Harvard has reported a very high incidence of it with the kids that come into their clinics. But these are kids who have a lot of difficulty regulating their emotions, and they're likely to have episodes where suddenly they you know, just lose control, and you know, they may be you know, get manic and excited, talking fast and moving fast and you know, overexcited, and then that same person may you know, find that they're just bummed out and they don't have any interest in doing much of anything. And sometimes those episodes last for just a few days, and sometimes they'll last for weeks at a time. And that's a case where you're probably going to want to get another consultant to give you a hand in looking at this. If the level is too high, there's some or it's made worse by stimulants, then guanfacine or mood stabilizers might be better. But you know, if you've got somebody where their moods are stabilized, then stimulants might be helpful, because sometimes they still need the help to be able to move it. These are some of the factors you can take into account in looking at comparing. Because for a while, people were saying, well, you can't really look at bipolar disorder in kids because they're hyper. Well, the fact is, what this is showing you is that the irritability and anger that you see in ADHD, yes, you'll see it, but it's not as marked as the more extreme form you see in bipolar. Hyperactivity is jacked up in bipolar. Inattention, yes, you have it, but it's worse in a person who's really got bipolar. Depression is plus or minus, and they're pretty deep depressions. Substance use, very high rates, particularly in adolescents and young adults with bipolar. You see some of it certainly with ADHD. And you don't generally see psychosis, psychotic symptoms in ADHD, but you certainly do in some people who are bipolar. So this is just talking briefly about some of the more severe things. Another thing which we often see is kids who are oppositional and defiant, and sometimes vindictive in ADHD. Now, the data that's come out on the combined type ADHD is saying it's as high as 35 to 50%. I think there's some questions that need to be asked about that. But the thing is that for oppositional defiant, it may be very quick, impulsive kinds of response, or it could be just a very sullen thing. But usually it also involves some overt physical actions, like a kid running away or hitting people. Onset usually is about 12 years old. Doesn't usually last. I mean, most of them do not go on and develop conduct disorder, but on average it lasts about 6 years for most people. But it may respond well to stimulants or guanfacine. Conduct disorder, of course, is more serious delinquent behavior. It's not something you see frequently with ADHD, but many delinquents do have ADHD on top of other things. But these are people who are physically cruel to people or to animals, or theft where they're confronting somebody, like purse snatching, setting fires, or very persistent truancy, almost always accompanied by high risk of disorders. And that requires a much more comprehensive treatment. Sleep problems, though, are things that you often will run into when you're seeing kids and adults that have ADHD. And it's important to follow up in your interviewing to try to get some sense of what it's like. Usually I ask, what time do you go to bed at night? And then if you get into, and they say, okay, well, I go to bed at 10, or I go to bed at 9, or I go to bed at 12. Okay, well, if you get in bed at that time and you say, okay, I want to go to sleep now, how long does it take before you can actually get asleep? And some people say, 10, 20 minutes or something like that. And what we get interested in is when it gets more than half an hour frequently. That many times people with ADHD report that they just can't shut their head off and be able to get to sleep. Sometimes they're worried, but sometimes it's not even worry. It's just, they're not able to talk. Now, these are things where one of the first things you've got to check is if they're taking medicine for ADHD, if they're taking it too late in the day, that could cause difficulty falling asleep. But you want to look at their sleep schedule, what the routine is for getting to sleep. With adults, you have to look at the risk of obstructive sleep apnea. And there are some medications that can be used for this, but it's important to ask about sleep, even if you're not going to be the primary person who's going to deal with it. OCD I mentioned earlier in that one case, and you hit about 10% to a third of kids with ADHD have this, but they often don't talk about it. And, the typical picture people have of OCD is somebody who's a compulsive hand washer. But the one that you see far more frequently are kids where they just have a lot of difficulty in being able to write. Because, the executive functions are involved in organizing your thoughts and being able to put them together in sentences and paragraphs. When you're reading, you've got the words in front of you. When you're doing math, you've got the numbers. But when you've got a blank screen or a blank piece of paper, that's a whole different task. And it requires much more in the way of executive functions. And this excessive perfectionism is something that you'll often see in students, but you have to ask about it. Stimulants sometimes make it worse, but not always. SSRIs like Prozac, Paxil, Zoloft, Luvox often will help OCD, but they do not help ADHD directly. And often we need to use a combination of medicines like this, with stimulants plus an SSRI, or possibly some behavior therapy. Substance use disorders, these are odds ratios here. The likelihood for kids with ADHD to be smoking is better than double, almost triple the likelihood if you have ADHD. Drinking in a problematic way, about 1.5 to 1.7 times. Weed, it's just about double. Coke, double. Any substance use disorder, 2.6 to 3.4. And the medication, sometimes people think, oh, well, you've got ADHD, and so if we can treat that, then we will be able to help, doing the substance use problem. But if you've got somebody who's smoking weed several times a day or vaping it, or particularly if they're dabbing, where they're using hashish oil or something like that, that's highly addictive stuff. Hashish oil is much closer to 90% concentration of THC as opposed to something more about 10 or 15 in most of the weed that's available these days. And so this is something that you want to think about and look at, particularly with your adolescent patients. Substance use disorders, ADHD meds don't fix them, and you've got odds ratios here. Autism spectrum. Those of you who've been in the field for very long know that for a long time we were not supposed to make a diagnosis of autism spectrum and ADHD together. That changed with DSM-5. It's finally recognized now what had been clear in the research for some time, and that is that many of the people who have autism spectrum disorders also have ADHD. And it can often be a big help to them to be able to get that ADHD addressed. The most problematic group in terms of difficulties with autism spectrum are the high functioning. More than half of the children who are identified with autism spectrum at this time are kids who are developmentally disabled and also are very much delayed in language development. And the ones who are not picked up, usually they do the count on that for kids at 8 years old, and it misses a lot of the higher functioning kids who have what we used to talk about as Asperger's. That diagnosis has now been taken out, which I think was a mistake. And it's subsumed under autism spectrum. But the fact is, many of these kids on the spectrum do benefit from treatment of ADHD. We also to take a look at OCD, which is quite common as a comorbidity. But the other thing you notice, I was saying, titrate cautiously. You want to watch to be sure that the doctor who's prescribing is cautious, because with these kids, we generally mark them as SBC, meaning that they are sensitive body chemistries, and when you give a standard dose, that's very likely to be too much for them. So in summary, it's important to get multiple perspectives when you're doing an evaluation. You want to get rating scale data from if the child is 8 or above, from the kid and from the teacher and from the parents. And you want to talk with people and get more details of it. Get some sense of when the symptoms are making trouble and what's going on right. What do you do for fun? What is there that that you're able to do that you enjoy? And take a look at the wide range of possibilities for some of these comorbid disorders. And keep in mind that often it's not an all or nothing thing, but it's a matter of recognizing that it's both and. Now, I wanted to mention also just a few of the questions. If you look at the rating scales and I hope you will take a look at them because they've been out now, or they'll be out as of Sunday, just a couple of days from now. There are some questions that are tied to looking at some very specific symptoms that you may want to ask more questions about it if they're scoring. And remember that the scoring system on these scales is not a usual 0, 1, 2, 3 thing. It's, is it a problem? Is it a little problem, a medium problem, or a big problem? We find that that is better at picking up the difficulties that many of these people are talking about. But I just wanted to mention, for example, I'm looking at adolescent scales and also the 8 to 12-year-olds. And there's a number of items, for example, on the adolescent scale, number 2, number 31, number 40, and 47, and 54 are all looking for stuff that has to do with problems with impulsive behavior. And on the 8 to 12-year-olds, it's 31, 36, 40, 41, 45. And you can read over, just look at the content of the questions. There are a number of them that are picking up more anxiety. Some of them pick up difficulty in completing tasks and slow processing speed, anger and irritability, depression and OCD. So the point here is that you want to carry on a conversation and ask questions that will give you an idea of how, what other things might be going on here. Now, I'm looking, we have just a couple of minutes left, and I see that some people have sent some questions in, and let me respond briefly to these in the moments that we have left. One question is, could I talk a little more about the 43-year-old mother who was concerned about midlife onset of ADHD? For that, I would refer you to my website. It's Brown Clinic. And you can take a look at that website, Brown ADHDclinic.com, and we've got papers posted there, 3 papers that we've published on the use of stimulant medication to be able to help women in menopause who are having an onset of difficulties which they hadn't had before, but it looks like ADHD, though there may not be the full symptoms. I've got a question here about, they've seen this, doctors reporting, I've seen several reports on children and adolescents with full-scale IQs of 80 or below who are diagnosed with ADHD. Yeah, I think that there are some people whose scores, you know, we all know that sometimes you don't pick up everything in a full-scale IQ test that's going to, that full-scale thing may not pick it up, because there's sometimes they've got really, you know, pretty good strength in some other domains. And you certainly can see ADHD in kids that are quite young. There's a question here about, do we have a set of rating scales for young children? Yeah, we do have rating scales that are published for young kids, age 3 to 7, and they're normed on that age group, and I would encourage you to take a look at that. And looking for other questions. If a parent teacher completes the executive function attention scales on a child or adolescent with this profile, what should we interpret? Well, you look at what, you know, my point is that you look at what issues that person is indicating they're having trouble with. And sometimes the parent may be picking up something that the kid is not noticing, and sometimes the kid is picking up things that the parent hasn't noticed. And we've looked at several of those in time. So the point is not just to you know, look at the score, but also look at the pattern and see if there are a few questions that are you know, strikingly high, and that you might want to ask some more questions about, because your best tools for assessing executive function, I would argue, are not neuropsychological test batteries, but well-conducted clinical interviews, talking with the patient, talking with the parents, and getting information from the teachers. and then looking at a normed rating scale. And these, we believe, are rating scales that will allow you to be able to do that in a way that you can find very helpful. So we've exhausted now the time that we have. I'd like to thank you very much for tuning in. And you'll see on the screen now there's a bonus offer in terms of if you wanted to order fairly soon. And we'd be happy to hear from you in terms of what your experience is in trying to deal with this. So let me just say thank you very much. I appreciate your interest in this, and I hope that you will find it helpful.